This is a lecture I've titled, What's Nutrition in CKD? New Guidelines and New Opportunities for Physician and Patient Empowerment. So why this topic? Well, I picked this for a number of reasons. Being in the nephrology clinic for the last couple of years, I've found that more often in the clinic, I find myself talking about nutrition, and patients seem to ask more questions about what they can eat as opposed to what they can do to control their blood pressure, to the fact that I feel that I end up spending at least as much time, if not more, talking to patients about nutrition and things they can eat, even more common things than you think of that we talk about in the clinic, such as blood pressure and progression of kidney disease. So I didn't feel very comfortable with the recommendations I would give them. I thought just telling a patient you need to be on a low sodium diet, 2,200 milligrams, Google search that, and then send them out the door wasn't exactly the best option. I really wanted to get a hold of this and really learn these restrictions and guidelines, what kind of changes we can make, and then try to put this in a way that I can have the patients understand and be able to take control of their own health going forward. Selfishly, I wanted to learn a lot more about nutrition, so I did that. Another reason why I picked this topic was because I've had my own kind of nutrition fads that I've been on. I've gone vegan, I've been vegetarian, I've been on muscle milk shakes and creatine and all that stuff. And it's just really important that I learned a lot more to be able to know what I'm putting in my body and what the patients are putting in their body as well. And then lastly, I picked this topic because food has always been a big part of my life. On my 16th birthday, the first thing I did was start working in a restaurant. I've had about 10 years of work in the restaurant industry, whether that's serving or bartending, even dishwashing. Even more important than that, I spent about 7 years of those 10 with direct management of food or preparing food, cooking food, and getting it out to customers. Here's a picture of me back in college when I was working the line, when I was in the middle of cooking. This brings the question, does nutrition matter? If you just open up a web page, CNN, MSNBC, wherever you get your news from, there's always sections on diet and new things that are coming out and new studies that are coming out based on these diets, as well as entire books that are being made, just focusing on restricting certain diets. And as we know, Mediterranean diets, DASH diets, they've been shown to lead to some healthier lifestyles. There's entire sections, as I mentioned, on the news pages when it's only about health and food. And this is an entire business. A lot of people are making their entire lives off of just making these cookbooks and these certain styles and having cooking shows and YouTube channels. With these dietary restrictions, are there any clinical consequences that come from this? And as I mentioned already, the DASH diet has been shown to decrease blood pressure. The Mediterranean diet has been shown to improve lipid profiles and cholesterol levels. Depending on which study you look at, it's been theorized that up to 90% of type 2 diabetes and up to 60% of hypertension could be prevented if only we could get people to take a little bit more control of their life, eat a little bit healthier, and exercise more. I've shown how it mentions in the general population. What about specifically looking at CKD? This article came out in 2019. They did this large meta-analysis. They looked at over 18 studies, tracked them for over 10 years, looking at well over 600,000 patients. Basically, what they did here was what we do in clinic. We try to get patients to eat more fruits and vegetables, eat more nuts and low-fat dairy, avoid the red meats, avoid the sodium. And they tracked these studies out and they looked for the prevalence of any clinical outcomes. They were able to make a couple associations here. As you can see, this healthy dietary pattern was associated with lower development of incidence of CKD and lower incidence of albuminuria. And so even more recently, in January of this year, there's another study that came out specifically looking at the Hispanic Latino population. They looked at 3 different trends of diets: the Alternative Healthy Eating Index, the DASH diet, the Mediterranean diet, and then kind of looking at those clinical outcomes and seeing if they were able to detect any differences. They showed that there was actually a decrease in the amount of GFR decline, so a decrease in the progression of the CKD, as well as a decrease of protein that was seen in the urine. These are all retrospective studies, but it just goes to show that there is maybe something here, something that we should pay more attention to. And this is obviously something KDOQI thought was important as well. They first came out with their update, this large comprehensive update that was released in 2020. This was the first overall encompassing update they've released in 20 years. They have released some smaller, more specific recommendations, but nothing as big and vast as this. This was an over 100-page document put together over a couple of years. It was NKF partnering with the Academy of Nutrition and Dietetics, as well as the International Society of Renal Nutrition and Metabolism. They released this document, which we're going to go over the next half hour, 45 minutes. Just to jog your memory of how long ago that was, and we were long overdue for an update. If you remember listening to the radio at that time, Faith Hill, Breathe was all over the radio. You could not get it out of your mind, which I found very unfortunate because the best band of all time, Blink-182, put out the best album of all time, Enema of the State, and they just could not beat that spot. What else was going on 20 years ago? Well, Bill Clinton was president. We had this whole hanging Chad debacle, and Gore and Bush took their case all the way to the Supreme Court that year. There was this awesome football game that I remember watching. Titans were down almost 16 points. They were driving in the last play, last second of the game to tie the game up. It ended up getting stopped 1 yard short of the end zone, which would have tied the game. Kurt Warner went on to retire and ended up becoming an announcer. This was the infamous 1 yard short game, if anyone remembers that. And if you can believe it, Oprah has released her 20th anniversary of her Oprah magazine. That's how long this has been going on for since the release of that. And then finally, this guy, if you can even recognize him, used to look like this 20 years ago. So it's been a long time. There's been a lot of new studies and things that have come out. That's what I want to focus on going forward. What can you expect to hear from this talk? I'm going to talk to you about protein, sodium, phosphorus, and potassium guidelines, and then we're going to talk about some specific diets that KDOQI does mention. Then the last part of this lecture, we're going to talk about how to read food labels and how we can take these guidelines that I've talked about and try to express them in a way that is easy for our patients to understand. First, we're going to talk about protein, and I'm going to start off with a clicker question. So when I get done with this, I'll give you 10 seconds to answer, then we'll go over the answers. So your longtime patient JB comes to your office for a follow-up visit. He's been following with you for 10 years for minimal change disease, treated with steroids once, been in complete remission, and has been completely fine since. He's meeting his girlfriend's family for the first time this weekend, and he wants to cook a meal that will impress the family and prove their daughter is in capable hands. Coincidentally, her parents also have CKD. He provides multiple protein choices and asks you for your advice. What entree would you suggest JB cook in order to impress his girlfriend's family and protect their kidneys? And let's assume that that's 70 kilograms per person. We have a double quarter bacon pounder, JB's world famous double quarter pounder bacon cheeseburger, an 8-ounce Wagyu New York strip steak, a 6-ounce distilled seared tuna, 3 ounces of blue cheese butter, 4-ounce bacon wrap filet with sauteed mushrooms, or a 9-ounce pan fried beef liver. And I'll give you 10 seconds. Okay, maybe a little bit more time. Okay, everyone thinks that the tuna is the best option here. Just to let you know, 70 kilograms per person, you're going to see that we're going for 0.6 grams per kilogram. That's 42 grams of protein. Let's see what we have here. The world famous bacon cheeseburger, 20 grams of protein per quarter pound of ground beef. That's 40 grams. 2 strips of bacon gives us 6 grams. The cheddar cheese is 7 grams with 14 grams, and the bun is Force. That gives us a total of 64 grams. As I mentioned, that's above what we're looking for. The 8-ounce Wagyu New York strip steak, that's 35 grams every 4-ounce protein portion. That's 70 grams of protein. That 6-ounce distilled seared tuna, which we think is the winner, 21 grams for every 3 ounces of fish, and then 7 grams for every ounce of cheese. That's 63 grams. That sounds like it's too much. The 4-ounce bacon wrap filet mignon with the sauteed mushrooms is 35 ounces for every 4-ounce portion. So we're at 35 grams. That bacon strip is 3. The mushroom is basically negligible, 39 grams. Then we have the 9-ounce pan fried beef liver. That's 22 grams per 3-ounce portion for 66 grams. So the winner here is the 4-ounce bacon wrap filet. What I want you guys to see here is when you're really talking about protein, what it comes down to is knowing your portion sizes and expressing that portion control for the patients. Because as you can see, an 8 ounce is already going to put most people over there. So I'll get to that later, but portion control is very important. Moving on to protein, why is it important? Well, KDOQI mentioned several things, and they're all common sense things that we've all known now. If you have reduced muscle mass, what does this lead to? This leads to having higher surgical post-op complications, increased length of stay while you're in the hospital. There's decreased physical function, a decreased quality of life based on questionnaires they've given patients, and an overall shorter survival. And that's why this is such a big deal before you discharge a patient. You really want to make sure that they are strong enough to get home to avoid these type of things. Protein intake itself is the balance. You're constantly turning over the protein that you take in. You're constantly breaking down proteins and then building them back up. There's this kind of level that we want to get to where we're balancing this with where we're not having any muscle atrophy or breakdowns. We're taking in enough proteins, but we're also not taking in too many proteins that are leading to overworking of the kidneys and progression of CKD potentially. There's multiple theories as to why that happens, and I'll get to those in the upcoming slides. First, let's talk about too little protein. This is the PEW, the protein energy wasting state. Basically what this is it refers to the state of nutritional and metabolic derangement in patients with CKD. This is characterized by the loss of systematic body protein and energy stores. What does that look like? So patients with CKD, they build up these uremic toxins. There's this loss of kidney function over time that gets worse. What this leads to is this overall decrease in their good nutritional intake. Not only that, it's also compounded by multiple things that may be causing the kidney disease. For example, diabetes. They may have underlying cardiovascular disease. If they're on dialysis, they're in a hypercatabolic state. They're breaking down those proteins and they're wasting more energy. and you have a bad hormonal profile with CKD. You have hyperparathyroidism and metabolic acidosis, which eventually can lead to bone breakdown and frailty. I already mentioned one of the consequences of this protein energy wasting state, that's frailty and bone breakdown, which can eventually lead to depression. If you're in this Q energy state, you're more prone to infections, and you're also more prone to cardiovascular disease, which can worsen the Q energy state. Is this something we really need to worry about? Well, by the time patients come to see us in the nephrology clinic, they're generally around stage 3 at least, anywhere up to stage 3 to stage 4 by the time we first see them. As you can see by this diagram, at least 20% and up to half of those patients, depending on the level of kidney dysfunction, may already be in this Q state. If you have a patient who has CKD stage 5, especially if they're on dialysis, you can see that well over 3/4 of patients are undergoing this. Part of this has to do with their appetite and how these uremic toxins build up. As the GFR decreases and uremic toxins increase, they get more anorexic and just are not able to keep up with their dietary needs. I've talked about too little protein. Let's move on to too much protein. The typical or recommended amount of protein in a diet is 0.8 grams per kilogram per day. It's been seen that the typical Western diet is 2 times the recommended amount of protein, which is close to 1.6 grams per kilogram per day if you're eating a typical Western diet. Multiple studies have shown that over 1.5 grams per kilogram per day have been shown to have bad effects, which I'm going to get to going forward. Since this is a nephrology talk, what is the theory behind what is actually causing the damage specifically to the kidneys with these proteins? As we know, there's the single unit, we have the nephron, and then we have the capillary space, the afferent and efferent arterial. We have the capillaries here with the Bowman's capsule, and then the filtration into the urinary space, and then out to the collecting system. This space needs to keep a normal, or at least a sustained pressure in order to A, keep the filtration going, and then B, keep from causing any damage. So what's been shown is if you give someone a high protein diet or a high protein load, especially an animal protein intake because of the amino acids it's associated with, it undergoes a series of mediators that ends up leading to an increase of the GFR and the renal blood flow up to 30%. In order to accommodate that, you have to dilate the afferent arterial. The Bowman's capsule ends up stretching as much as it can in order to accommodate for this extra filtration in the urinary space. You can see that if you're having a high animal protein diet again and again and again, if you are a kidney disease patient who already has decreased functioning nephrons and the remaining functional units of the kidney are already overworking and compensating, you can see that it's going to be more prone to damage because this space will be maximally stretched and it won't be able to accommodate any more of this blood flow. And not only that, but the stretching of this space causes the mesangial cells to undergo a series of things, which has been shown. They lay down extracellular matrices, they lay down collagen, and they increase the expression of TGF beta, which in studies shown to lead to interstitial fibrosis. So with knowing that information, it brings the question of what if we are able to remove that insult? What if we avoid those high animal protein intakes? Does that make a difference? And in this study mentioned in this 2017 review, they took animals, put them on high protein diets, and then took it away and were able to measure the pressures on both sides of the arterioles. And they showed putting patients on a low protein diet leads to vasoconstriction of this afferent arteriole. What does that do? That's going to decrease the pressure in the Bowman's capsule in this space, and it's going to decrease the stretching, decrease the production of the TGF beta from the mesangial cells, and allow for good adequate filtration without damaging or scarring the kidneys. And then in turn, that actually leads to a favorable angiotensin pathway where it's going to vasodilate the efferent side. And this can work hand in hand. It's very similar to what we do and why we put patients on ACE inhibitors to decrease the pressure in this space. So proteinuria itself, what we know is that patients who come in with a lot of proteinuria, minimal change disease, or even more recently, the COVID patients with proteinuria, who have 15 to 20 grams of protein, you biopsy these patients and you're going to see some podocytopathy on those biopsy specimens. Proteinuria itself has been shown to be associated with progression of CKD. And not only that, but animal proteins specifically are kind of a double hit because you have your meats and even some sugars that when you cook them and you char them, while it adds all the flavor and taste and everything that we really like and enjoy about eating these animal proteins, it unfortunately undergoes this reaction called the Maillard reaction, which forms not only everything that we like with the food, but also these age products, these advanced glycation age products. There's multiple of these. What I want you to know is that these are very reactive aldehydes, and they have been shown to, if a cell has receptor for these products, it will alter the structure of the cell, and the cell will eventually start to lose function. It'll break down and eventually it will die. So looking at the podocytes in a normal functioning kidney without any damage, there's a tight seal here. They're keeping in all the proteins. And then now you start having a lot of animal protein intakes and you start stretching this Bowman's capsule, as I alluded to earlier. If it's stretched too far and there's damage, it'll start leaking some of that protein. Then now you add on, you're eating these foods that are produced in all these ages, these advanced glycation end products. And unfortunately, podocytes and mesangial cells have both been shown to have receptors for these reactive aldehydes. It's going to damage the podocytes, it's going to damage the mesangial cells, and lead to even worsening proteinuria over time, especially with increased loads and insults. This leads us to this kind of Goldilocks phenomenon where if we give too much protein, we're going to have kidney damage. We give too little protein, we're going to have kidney damage. What we're trying to do as nephrologists and the KDOQI outlines is they're trying to find the just right amount of protein in order to keep those kidneys happy and functioning for as long as we can. Getting to the guidelines, what does KDOQI say about protein? Stages CKD 3 through 5, they recommend a low protein diet. So that's going to be 0.55 to 0.6 grams of protein per kilogram per day. There's also another recommendation for very low proteins with supplementations to get to that level, which I'm not really going to focus on too much. I just want to focus on the low protein diets versus the normal proteins or high protein diets. There is a caveat here for diabetics. They give you a little bit more leniency with the protein, A, because they're a little bit more of a hypercatabolic state, and B, because you have to worry a little bit more about hypoglycemia and glucose control. Benefits of protein restrictions have been found to be vast and many. I'm not going to touch on all of these, but I just want you to see that there is a lot of reasons that you could put patients on this low protein diet, and I'm going to touch on a few of these going forward. So this diet came out in 2018. This was a very large meta-analysis study. They used criteria of having at least 30 participants in it, and you had to have data showing that you had patients on low protein diets versus a normal intake, which is 0.8 grams per kilogram per diet. They were actually able to compile over 16 trials and come up with some pretty interesting findings. First off, in this plot diagram, I just want to point you to, there's the lower protein diet on this side, the higher protein on the right. Here, we're looking at the risk of progression to end-stage renal disease, and this was found to be significant that there was actually a 4% reduction in the patients in the low protein diet who went on to develop end-stage renal disease. Looking at the low protein diet on the left side, comparing a whole protein diet on the right, this is comparing overall risk of all-cause death. And while this was not significant, there was a trend towards the low protein diets. And then looking at the favorable change in the serum bicarbonate after 1 year, now the low protein diets on the left, they had a much more favorable bicarb level as compared to the high protein diets. They also were able to add the very low protein diets. This is one of the only times I'm going to talk about this. And it's really just because I want you to see the trend where if you put patients on an even lower protein diet, the risk of progression to end-stage renal disease was less. On a very low protein diet, the risk of the decline in the GFR, the kidney function, was even less. And if you look at the 1 year GFR, now the very low protein diet on the right, the trend was towards having a better GFR with the less amount of protein that you took in. Overall, what does KDOQI say about low protein and the benefits? Well, they mentioned specifically that low protein lead to decreased mortality, decreased progression onto end-stage renal disease, and increased quality of life. There was not enough information to say whether or not there was an effect on GFR. However, they did mention that most studies are comparing 0.6 grams per kilogram compared to 0.8 grams per kilogram. As I've already mentioned, most people are eating 1.6 grams per kilogram. So if we had some studies showing that level of protein intake, could we see some changes? That's just some room for future studies to think about. Comparing the diets, there was no change in albumin levels, and there also was this favorable improvement in total cholesterol and lipid levels. So with that being said, it comes to question, are low protein diets safe? KDOQI specifically mentions overall results of dietary protein restriction over 2 to 3 years in patients with advanced CKD was found to be safe. Do we have any studies that can back up why that would be the case? The answer is yes, we do. There's this guy, Giraboto, who came out with this study, putting patients on different protein diets and looking at their efficiency of protein recycling. This guy's very interesting because in order to measure the protein intake, he actually came up with this, at least mentioned in one of his papers over 20 years ago. It's this AV phenylalanine measurement where you look at the forum, you give someone a protein load, you measure the phenylalanine on the venous and the arterial side, and since phenylalanine is not digested, the difference on each side is going to tell you how much is being incorporated into the body, into the protein. So if the phenylalanine is higher on the venous side after a protein load, that's a sign that there's a lot of breakdown and it's not being incorporated into the body. If there's less on the venous side compared to the arterial side, that's a sign that those proteins are being taken up into the cells and being used. With that method, he was able to put patients on 1 gram and low protein diets, and I'll get to those results here. So you're going to see this diagram about 3 times. I just want to walk you through it. You take in your dietary protein load. This is a gram per kilogram person, 70 kilogram man. He's taking in a gram. You're going to digest some of those proteins. Some is going to get undigested. It's going to get pulled into this amino acid pool. And again, we're constantly synthesizing and breaking down these proteins. So at a gram per kilogram per day, the efficiency, the enzymes that you're using to recycle those proteins is at a level of 60 to 65%. Okay, so the amino acid pool stays the same, your total body protein is staying the same, you have a total body load of 250 grams, and everything that comes in, that 70 grams, is oxidized and sent out without any muscle atrophy. Now what happens if you put a patient on a low protein diet? He was actually able to coin this term called adaptation, where if you put someone on a 1 gram per kilogram diet compared to half of that, what happens is the enzymatic reactions in order to maintain those proteins increase to the point where you become more efficient in recycling those proteins, as opposed to what we just saw, where you're recycling 66% of those proteins and you're losing 34% of those amino acids. Now you're going to be recycling 76% of those proteins and only losing 24%. What happens if we put a patient on a 42 gram, that's that 0.6 gram per kilogram diet? What do we see? You have the decreased dietary protein intake. Again, you're going to digest it and put it into the amino acid pool. That efficiency, as I've already stated, goes up and increases in order to decrease the degradation and maintain that protein synthesis. So despite the fact that you have a total less protein load, your body protein remains the same. You're not breaking down any proteins. That 42 grams that comes in is the 42 grams that comes out, and you maintain the same. And that's what's coined adaptation. Is there a point where this gets malproductive? And actually there is, and that's a term called accommodation. For example, in this same 70 kilogram man, we put a patient on a 25 gram protein intake. The dietary protein is very reduced and the overall amino acid pool decreases. And how did this happen? This is because while you're trying to decrease the degradation of those proteins, the synthesis decreases because you don't have enough of the amino acid pool. You're not able to become efficient enough to adapt to that lower protein intake. What happens is you end up overall getting muscle atrophy and losing those proteins. And this is what happens in this protein energy wasting state. Where did this happen? Well, he was able to show this happens at 0.4 to 0.5 grams per kilogram per day. If we remember back to the guidelines, we say that we should be at 0.5 to 0.6 grams per kilogram per day. Theoretically, we should avoid ever getting into this poor energy wasting state. Other things when we talk about our patients, we know that as CKD progresses, you lose muscle mass. Is there any studies that show, or the things that we can do in order to keep that from happening? And so actually the answer is yes. The study came out in 2019. This was the REN-X exercise study. What they did was they looked at patients with pretty advanced CKD stage 4, and most of them in their upper 60s, and they put them on 150-minute training intervals in a week. 60 minutes of that was endurance training. The other 90 minutes was either balance training or strength training. And then they followed them over a year, and they were able to come up with some interesting findings. In both groups, the sarcopenia, the muscle loss, there was no progression of the muscle loss. In fact, in the balance training group, you can see that the lean mass increased. Both groups, the fat mass had decreased. And in some studies and in some populations, myostatin is considered an inhibitor of muscle breakdown. In both these groups, myostatin went up, indicating that there may be a decrease in the actual muscle breakdown. It's important to tell patients, if they can tolerate it, to keep up with a good exercise regimen. We've talked about protein. Now let's move on to what they say about salt. So KDOQI in stages 3 through 5, they recommend an intake of less than 100 millimoles per day. That's 2.3 grams of sodium in a day. And why do we do this? Because it's been shown to reduce blood pressure and improve volume control. It's been shown to work synergistically with medications that we're giving our patients to reduce that proteinuria. It's also been shown to achieve better volume control as well as a more desirable weight. With that, I just want to poll the audience here. How much is 2 grams of sodium? We have a quarter cup, we have 1 tablespoon, we have 1 teaspoon, a half a teaspoon, or a quarter teaspoon. I'll give you 10 seconds to answer that. Salt Bay wishes you guys luck. Okay, let's cap it. It looks like the winner is the size of a penny, a half a teaspoon, and that is close. The answer actually is 1 teaspoon, which is the size of a quarter, which I still feel is not a lot. Moving on. Salt load, why is it an issue? As we know, CKD patients are prone to having issues because they have a decreased salt excretion. What's considered a high sodium intake? Well, generally that's considered anything more than 4 grams a day. Just for reference, going forward, 2 grams of sodium is close to 5 grams of salt. This is your table salt and your sodium chloride. If we're looking at the average sodium intake on the Western diet, if you're a male, you're at 4.2 grams a day. So this is already in the high zone. If you're a woman, you're in 3 grams per day territory, which is already, if you're on a restricted diet, just your normal diet is going to be too high in salt. I have another poll question for you guys, just to see what you guys think. How much salt is in your typical turkey sandwich? Is it 300, 600, 900, 1200, or 1500 milligrams? Okay, 1200 milligrams is the guess, which again is pretty close, but it's not quite the answer. Let's see how much is in there. It's 1500 milligrams actually. 2 slices of bread, that's 400 milligrams. You add some mustard, that's another 120. 6 slices of turkey is close to 700. Then you add the cheese, that's another 310 milligrams, and you're already at 1522 milligrams in just that sandwich. This is your lunch. That's not even counting the chips that you're eating or anything else that you've had that day. It's very important to just kind of be conscious about where the salt is coming from. When we talk about where is the salt coming from, most of it actually comes from the foods that we've chosen to eat. Over 75% of it comes from the processed foods and when we're out to eat, restaurant foods. And really only 10% of that comes from added from salt shakers. That's including when you're cooking. That's also including the salt shaker at the table. So you will talk to your patients about how I'm a low salt diet, and they'll tell you, well, I don't have a salt shaker at my table. I don't ever cook with salt. That's when you really have to dig into, that's only a small fraction of where the salt is coming from. You really want to get into the food diaries and get into, educate them on where those salt sources are from. Just some other kind of sneaky sources of salt. A third of a frozen pizza is 1740 milligrams. And I know myself, I can eat an entire frozen pizza in a day. You really, if you're on a low salt diet, this really kind of puts you on some restrictions that you got to be aware of. You may go out to eat and think you're eating healthy, getting that 6-inch Subway club, but that's already got 2.3 grams of salt in it, and you're going to get a foot long. So there you go. You're at your entire intake for a day in just that meal. And again, that's not even counting the chips that you're going to get on the side with that. It's very important that we educate our patients about where to find these things, which is I'm going to get to more in the later talk of the lecture. Back to the KDOQI recommendations, what do we know with salt and some clinical outcomes? What we know, and we've known for a long time, is that high salt diets attenuate, affect, and decrease what we're trying to do with those antihypertensive medications. It's also been shown that it attenuates the effects of low protein diets and it worsens that proteinuria. There's been studies that show where they take patients that have a baseline proteinuria, they put them on a low salt diet, and that proteinuria significantly declines. They make no other changes to the regimen, and they put them back on that regular diet they were eating 3 months later, and that proteinuria returns, indicating that this high salt load has something to do with that protein excretion. Another thing that we've known for a long time is the more salt that you retain, this leads to volume expansion, which is going to correspond to worsening hypertension and more difficult to control hypertension. And excessive sodium intake has been shown in multiple studies to be considered toxic to blood vessels, leads to inflammatory mediators, leads to oxidative stress. It also leads to endothelial dysfunction, which in turn is going to worsen hypertension. So what do we know about salt and the progression of CKD? There's actually this pretty large study that came out that's had a lot of post hoc analyses on it because it was such a large study, the ramifical efficacy and nephropathy trial. It was one of the major studies that are the reasons why we actually use ACE inhibitors in CKD. Because it was such a large trial and followed for so long, there's been a lot of post hoc analyses and subgroup analyses they've been able to do after the fact. So this group in 2012 did this analysis where they broke all the patients in the study out. They followed them, as you can see, for over 4 years of data, and they put them into low salt, medium salt, and high sodium diet intakes. The low sodium diet was considered less than 100 millimoles per day. That's the goal in a low salt diet. 100 to 200 was the medium sodium, and the 200 and above was the high salt diet. On the left side of this chart, you can see the percent of patients without end-stage renal disease. Everyone started out not being on end-stage renal disease and dialysis. And as you follow them over time, the lower this number gets, the more people who progress to end-stage renal disease. This top dotted line is the low salt diet. This is the high salt diet. As you can see, a substantially more amount of people developed end-stage renal disease compared to the low salt diet. Not only that, but the low salt diet compared to the high salt diet was actually found to be clinically significant, statistically significant, as well as the medium salt diet compared to the high salt diet. What do you know about salt and the development of cardiovascular disease, specifically in the CKD population? The problem with answering this type of question is that a lot of the salt studies are done in cardiovascular disease patients. A lot of those studies cut out patients with CKD for a number of reasons. But we do have this CRIC study that's been going on for about 20 years now, thousands and thousands of patients, tons of years of data. Because of this, they're able to retrospectively dissect the data and do some analyses to see whether or not there's any trends here. They actually did this post hoc analysis where they looked at the 24-hour urinary sodium groups, put them into quartiles based on low, medium, high, and very high. We're looking at all the most common cardiovascular deposit disease endpoints, which is myocardial infarction, stroke, development of congestive heart failure, and then overall the total composite of all these. If you trend these patients out over 10 years, In all these charts, the yellow and the blue is the low salt diets compared to the high salt diets, which is in red. If you look at every single group, they were all found to be statistically significant. The development over 10 years, more patients in the high salt diet ended up developing MIs, more patients ended up having strokes in the high salt diet, more patients went on to develop congestive heart failure. If you're on a high salt diet, the overall composition of this is statistically significant. This again just goes to show high salt diet is associated with these things. So there are some controversies with salt. I wanted to mention, especially because I just talked about the 24-hour urine sodium collections. There are some people who question that validity, and that's because many patients are on medications that change the excretion of salt, and they also are at different levels of CKD, depending on when you measure the 24-hour studies. There has been some new data coming out that's showing maybe the sodium-potassium ratio is more important, especially when you're looking at blood pressure, to the fact that every 3-unit increase in sodium-potassium ratio can result in over a 1.6 elevation in systolic blood pressure. So we've talked about salt. Let's move on and talk about potassium. KDOQI specifically says patients with CKD stage 3 through 5, you should adjust that dietary potassium intake to maintain a level within the normal range. Whether they're hypokalemia, they say it's okay to add supplements or binders in order to maintain that goal. As composed to the salt recommendations where everything was very specific, you wonder why is there no specific recommendations for potassium? That's for a number of reasons. First of all, potassium, while it's tightly regulated, is very variable from day to day and week to week, especially because it depends what kind of medications you took that day, if you have a kidney injury or your kidney disease has progressed, how well your sugars are controlled, what acid level you have in your blood, and just how you're feeling that day, with whether you're having any GI issues or any nausea or any vomiting. They do mention there are some specific associations that we know between hyper and hypokalemia. Similar rates in the CKD population of hypo and hyper K, close to a fifth of them will have some sort of potassium issue. It's been shown that CKD has been shown to progress in states of hypokalemia. Depending on which studies you look at, both hyper and hypokalemia has been associated with clinical outcomes such as increased rates of death, worsening cardiovascular disease, as well as increased hospitalizations. Really what it comes down to is why there's no specific recommendations, because as you'll see, potassium is in a lot of really healthy foods that have a lot of other benefits. Trying to restrict potassium may cause deficiencies in other things we want our patients to have, namely an increased intake in fiber, those vitamins, antioxidants, and the intake of vegetable proteins. KDOQI also mentions the consequences of potassium in CKD are not entirely understood. They do make some associations. High dietary potassium is associated with higher mortality. Higher potassium excretion is associated with CKD progression. In some studies, it may be associated with mortality. And if you restrict the potassium in the intake, it has been shown to have overall increases on the general health of patients, as well as the stability of their underlying nerve function. I have another question for you guys. JB is satisfied with your recommendation, as he knows he will be able to impress his girlfriend's family with his grill master skills and perfectly sear those bacon wrap fillets. After explaining to JB that since his girlfriend's family has CKD, they may possibly have potassium restrictions, he again asked you for your expertise in choosing a low potassium side dish. JB provides you 5 options and is requesting input on which would put his girlfriend's family at the least risk for developing hyperkalemia. A, we have JB's special broccoli cheese casserole, a lime-infused avocado and tomato salad, loaded smashed potatoes, garlic and rosemary roasted grilled eggplant, or a cream spinach with goat butter and Parmesan cheese. I will give you 10 seconds to answer that. Okay, excellent. I'm glad you guys got this one right. This is great. So let's go over why this is the case. JB's special broccoli cheese casserole. 1 serving of broccoli is going to be high in potassium, 450 milligrams, and then you add the dairy. That's going to put you in the very high state, according to this chart. We have the lime-infused avocado and tomato salad. 1 avocado is going to have 708 milligrams of potassium, plus the almost 300 milligrams in that tomato, and then you add the lime, you're in a very, very high level. Those loaded smashed potatoes, I think some people picked that. Fortunately, the potato is going to be high with 620 milligrams of potassium, and then you add the dairy, you're way over the limit. Now, the garlic and rosemary roasted grilled eggplant is that the winner. 1 serving of eggplant is 110 milligrams. That looks like it could be a very good choice. The cream spinach with goat and Parmesan cheese. So the spinach is very high in potassium, almost 900 milligrams of potassium per cup, and then you add the dairy and you're way over the limit. The garlic and rosemary roasted grilled eggplant is the winner. And kind of the things I want you to take away from this is that there's certain things you can talk with your patients about. Green leafy vegetables are going to be high in potassium. Your starches, potatoes are going to be high in potassium. Anything citrusy, whether it's a citrus vegetable or a citrus fruit, are going to be high in potassium. Your avocados, your tomatoes, your oranges, and then anything dairy is probably probably going to end up pushing you over the limit for potassium. I'll get to some more recommendations for that in a second, but those are just some kind of rules of thumb you can have when you're talking with your patients. So let's move on to phosphorus. Statements on phosphorus. Patients with CKD 3 through 5, we recommend that dietary intake to maintain phosphate levels within the normal range. And it's important when you're talking to patients to talk about the bioavailability of that phosphorus, whether it's coming from animal, vegetables, or additive sources. I'll get to why that's important in a couple slides. What do we know about phosphorus? CKD, as similar to salt, leads to decreased phosphorus excretion. It increases this poor hormone profile where you have increased FGF23, increased PTH. And what do we know happens from that? It worsens left ventricular hypertrophy, overall worsens the renal bone osteodystrophy, worsens vascular calcification, as well as been shown to, according to some studies, lead to progression of CKD. Higher phosphate levels have also been found to attenuate the anti-proteinuria effect of the ACE inhibitors, which is what we're trying to achieve. It also attenuates the benefits of putting those patients on the low protein diets. So why is the bioavailability of phosphorus important? Depending on the source of where you get it from, the way that the phosphate is packaged, that determines how much is absorbed into your body. Vegetables package their phosphates in phytic acids and other phytate products that are harder to hydrolyze and break down, to the point where if you take in phosphate from a plant, only about 50% of that is going to get absorbed. Now you get into the animal products, and those are very easily hydrolyzed, and up to 80 to 90% of those are going to be absorbed. And if you're getting your phosphorus as an additive, such as it's in Coca-Cola or as a flavoring agent, 100% of that is going to be absorbed into the bloodstream. So as you can see, depending on the source where you get it from, that can really lead to a change in the phosphorus levels in the blood. What has been shown to work? Well, multiple studies have shown that putting patients with CKD on low protein diets leads to decreased phosphate levels in the blood. It's really important to focus on that bioavailability because of what I just discussed on the last slide, as opposed to just really focusing on the total intake. Although that is important, if you're going to have a goal, you want to try to get them to less than 800 milligrams per day. Moving on to dietary patterns. Patients with CKD 1 through 5, all patients are recommended really to be on a Mediterranean diet, and that is because it improves the lipid profiles. Other specific recommendations in CKD, they recommend placing patients on a fruit and vegetable increased diet. Why? Because that leads to decreased in body weight, decrease in blood pressure, as well as an overall net acid production. They do make some comments specifically looking at net acid production. And stage of CKD 1 through 4, they recommend reducing that through an intake of fruits and vegetables. Why? Because if you are able to increase the acid production, it has been shown to lead to a decrease in the residual and the progression of the kidney function. If you are using a fruit and vegetable diet, it is also okay to use oral supplementation with sodium bicarbonate or citric acid in order to maintain that level at a reasonable goal, which they believe is around 24 to 26. Why is this important? It's because of the acid load that's produced depending on what you eat. So animal proteins, when they're broken down, they contain sulfur-containing amino acids, mainly methionine and cysteine. And during the metabolism of this, they produce sulfates. What this leads to is an overall acid load in the blood. As you can see, the animal proteins, if you study the amount of acid after giving someone a different loads of different foods, you, instead of being at a neutral level, end up being positive, where you have more acid in the blood. As opposed to, we look at vegetable proteins, they contain higher levels of glutamate and other neutral-based foods. When they get metabolized, they consume hydrogen ions, and they tend to remain neutral. Not only that, but they're complex with other beneficial elements, such as these higher anionic potassium salts, such as citrate. This can actually be used to be excreted in the urine. Overall, this is going to lead to a more basic blood profile. Why is that important, having a basic versus acid profile? Well, correcting that acid in the blood leads to a decrease in the progression of CKD, decrease in the proteinuria, better overall nutritional status, and does lead to decreased mortality. Overall, what does KDOQI say about vegetarian diets? Well, you get better plant proteins for animal proteins, is the reason I discussed. You're going to increase a dietary fiber intake, increase your gut health, have a better and more favorable cholesterol breakdown, and better lipid profile. Your blood's going to be more alkalotic. It's been shown, interestingly enough, that there's a reduction of phosphorus as well as a reduction of FGF23. There's a study where they put CKD4 patients on animal protein diets and then vegetable diets, measured their FGF23 levels after a week. The animal diet had 29 picograms per millimole higher of FGF23. So you're on that vegetable diet. It also leads to reduction in total body weight, reduction in total blood pressure, and an increase in that potassium sodium ratio, which I've already discussed, can lead to better blood pressure. Overall, what does KDOQI say? They say, although the intervention studies examining dietary patterns in CKD are limited, there's consistent evidence from observational analyses on dietary patterns containing fruits, vegetables, whole grains, lean meats, low-fat dairy, and low-added salt, resulting in improved clinical outcome and notably mortality in CKD. A recent study also confirmed that intake of nuts, low-fat dairy products, and legumes is protective against the development of CKD. I think that's just a very powerful statement for them to say, and I hope I was able to get across why they said those things in the previous slides. This is all well and good, but where the rubber meets the pavement, so to speak, is we need to get our patients to understand this. That starts with the physicians learning about nutrition, but then taking that knowledge and be able to express that in a way that patients find easy to attain and understand, because controlling everything you eat can be difficult, but there are things that we can do to make this easier for our patients. When you're talking with your patients, what should you be focusing on? Caloric intake is important. Sodium, potassium, and phosphorus is important. Calcium and vitamins and fluid intake is also important, especially depending on what other diseases you have. I'm going to talk specifically on a few of these going forward. It's hard to discuss making dietary changes unless you know how to read a food label. When you're looking at a food label, when you're talking with your patients how to read one, you want to look at the daily value. Some good rules of thumb are if it's over 20%, it's high. If it's less than 5%, it's low. So you look at the daily value and then you start at the top. You want to see how much does this equate to into what I'm about to eat. Is it an entire container or is it one serving? Another rule of thumb is you can tell your patients to limit the things at the top half of the label, increase things at the bottom half of the label underneath the solid line. Those are just some good rules of thumb to use. Now, you'll notice looking at this that there's a couple things that are important that are missing, and that is potassium and phosphorus. Those, unfortunately, are not required to be on food labels. You really got to take the time to understand where to find these things and where to look for them. First, let's get back to talking about protein and what we should tell our patients. It's important to realize the protein content of food is different in what meat you get it from. Your red meats, your sirloin steaks, those are going to have more protein in it per portion, as opposed to your poultries, different cuts of chicken and turkey, which is going to be higher than your sea fish, which is going to be higher than your dairy portions, which is slightly higher than your protein or than your beans and proteins. Then it's also important to think about the source of the protein and how lean that protein is, especially if you are dealing with diabetic patients and things like that, or people who are trying to lose weight. It's important to think about how many calories are packed per that gram of protein. So a chicken breast and a pork loin is very lean, where it's going to have a decent amount of protein in it without a lot of calories. You start getting down to the red meats and the ground beefs, those are not as lean. Then you start getting into the dried beans and your corn and things like that, and those have a decent amount of calories in it, which is why you have to still be careful with those portion sizes, despite the fact that they're very healthy for you. And I wanted to just get it across that when you're talking about protein, portion control is really the best thing that you can do when you're talking with your patients. Important to have some rules of thumb. A 6 to 8 ounce steak is about 50 to 60 grams of protein. An egg is an ounce of protein. A portion of meat, fish, or tofu is generally 3 ounces. And a good way to picture that is it's the size of a deck of playing cards. And then when you're talking about dairy, a good way to picture a dairy food, a portion of that is about half a cup, especially when you're looking at milk or yogurt. That's going to be about the size of a tennis ball, which I'll show you soon. Then a portion of cheese is 1 slice. I'll get into the next slide why that's important. So when you're talking with your patients, it's important to get them to use their head where they're reading food labels and thinking about what they're eating and paying attention to what they're eating, as well as their hands. So I found this great figure that shows a really quick way that you can talk with your patients about measuring their portion sizes. That deck of cards that is also similar to the palm of your hand, and that's a good thing to use for meat serving sizes. If you're looking at a serving of cheese, that's not a slice of cheese, you can picture that as your entire thumb. If you're looking at how much should a snack be, that's generally a handful. Then getting to those dairy products, as I mentioned, a tennis ball is about half a cup. That's your dairy, that's your fruits and vegetables. If you're thinking about how much salt you want to use in a day, that's going to be close to a thumb tip. Not only that, an even quicker method, if you're looking at how much to have per meal, a good way to break that down is the protein should be the palm of your hand, carbohydrate should be the fist, and the vegetable portion should be 2 open stretched hands. We've talked about protein. Let's move on to how we talk to our patients about phosphorus. Then this is the last question. JB returns to your office 1 year later for his yearly routine checkup. His metabolics are balanced. He's feeling great. He states that he has had one of the best years of his life and believes he has found the one. The kidney-conscious bacon wrap fillets with grilled eggplant you suggested last year were a hit, and he secured the trust of his girlfriend's family. Now he's planning to propose at her family's yearly getaway in Myrtle Beach. He plans to bake a ring into that cake that's going to be served at the end of the dinner, where he's going to make his move. Keeping in mind his hopefully future in-laws' CKD history, which dessert would be the best source of phosphorus? The best as a low source of phosphorus. JB's Sell the Farm chocolate mousse cake, a blueberry corn cobbler, Italian ricotta cake, Coca-Cola cake topped with crumbled pistachio, or the yearly harvest pumpkin cheesecake. I'll give you 10 seconds. Okay, so yes, that is the answer. And everyone went with the blueberry corn cobbler. Let's break that down on the next slide here. We have JB Sell the Farm chocolate mousse cake. That is 300 milligrams per 3.5 ounce serving in the chocolate. Then you add the dairy. That's going to put you at a high level. Remember, we're shooting for less than 800 milligrams in a day. The blueberry corn cobbler, 18 milligrams per cup with 60 milligrams per ear. That's going to be a very low option. The Italian lemon ricotta cake, that's your ricotta cheese, 450 milligrams. And then you add some more dairy and eggs. That's going to be high. The Coca-Cola cake, while that has 60 milligrams per can, that's entirely inorganic. And the pecans have a relatively high amount, which is 277 milligrams per serving. Then you look at the yearly harvest pumpkin cheesecake. You have 1 cup of pumpkin with 168 milligrams of phosphorus. You add in the dairy, and you're at a high level for 1 serving. As you guys thought, the winner is the blueberry corn cobbler. What I want you guys to see here is that there are some trends that you can use when you're talking about phosphorus. Dairy products are high, chocolate is high, and dried nuts and squash products are also very high. Just to recap, these high phosphorus foods, we have dairy products, dried beans are going to be high in phosphorus, anything processed, whether it's meats, dark sodas, beer, canned foods, canned vegetables, and any junk foods are going to be high in phosphorus. So you really want to try to avoid those if you can. As I showed earlier, low protein diets end up leading to decreased phosphorus in blood in CKD patients. And why is that? Well, A, because of the source it's coming from the protein where it's packaged, but also because generally proteins will be packaged with phosphorus, and certain groups are worse than others. Oysters have a very high amount of phosphorus per gram of protein. Beef liver is always going to be very high. Chicken is somewhat better. And these kind of lean meats are a little bit better too. Your turkeys and your pork loins have a little bit phosphorus per gram of protein. Some other things to note are these dried beans, walnuts, peanuts, those are all going to be high in phosphorus. You have to be careful about those. And unfortunately for us beer drinkers out there, there's a lot of phosphorus in that. Or if you drink chocolate milk, again, because of the chocolate, there's going to be a lot of phosphorus in that per gram of protein, mainly because there's not a lot of protein, but still, you really want to mention with patients to be careful when they're intaking those things. So the problem with phosphorus is it's not on these food labels, so you really have to know where to look for it. You need to dig into what's in it. Anything that has phosphate in it is an additive. So it's in lasagna, mac and cheese, garlic, and almond milk. It's also going to be in cereal. 3 types of it are found in fast food fries. And as we all know, there's a lot of it in dark colored sodas. Really got to be able to tell your patients to read the food label and watch out for those things. Some general tips that are going to carry forward for the rest of the talk as well. You want to try to eat fresh. Most fruits and vegetables are low in phosphorus. Limit your cheese to a slice at a time. Know your portion sizes, especially with the meat and especially with the dairy. Choose lighter colored desserts if you're going to spring for that. Avoid sodas and beer. With phosphorus and potassium, you can boil out and leach that phosphorus as well as the potassium by putting them in water. You know, try to get them in as big of a bowl as you can. Soak it for at least 4 hours and then dump it out, and then you can cook with it, and it's going to have less phosphorus. There's also this concept called the phosphorus pyramid, which goes over just kind of some general trends. These kind of wild berries are a little bit better than the citrusy ones. Leafy vegetables are good for phosphorus. As you move up the chain, you have your grains and your breads, and then your meats, especially your shellfish. Then you get into your processed dairy products like your cheeses, and you really want to avoid anything processed at the top if you can. Let's talk about salt. Questions you can ask for if you're eating too much salt. Do you eat out several times per week? Do you buy food that is canned, boxed, bagged, bottled, or jarred? Do you eat too few fruits and vegetables, less than a pound per day? And do you avoid cooking meals for yourself? If you answer yes to one or a couple of these, you're probably eating too much salt. There's this popular belief that high salt food tastes salty. Well, if you look at the top 10 sources of salt, according to the CDC, you wouldn't naturally think that those are high in salt. Your breads and rolls, pizza, sandwiches, cold cuts, your burritos and tacos, chicken, and even a lot of cheeses you might not think have a lot of salt right off the bat because they don't necessarily taste salty. It's actually been shown that if you are on a high salt diet, this leads to adaptation to that high salt level. If you put patients on a lower salt diet for 2 to 3 weeks, they'll start to notice some changes where if you put them back on the previous salt diet they were eating, they'll think that it's very salty. So you can actually change your taste if you are able to stick with a low salt diet for a period of time. There's some other sneaky salt sources I want to talk about. Shrimp is going to be loaded with salt, 800 milligrams per portion. Anything canned is very high in salt. So this is 33% in 1 serving. Well, there's almost 3 servings in that 1 can. Salad dressings are high in salt. You can see that it's 22% if you use 2 tablespoons, and nobody uses 2 tablespoons per their salad. You're always going to use a lot more than that. So you have to be careful. Anything canned, especially these condensed soups, are going to be loaded with salt. So what are some tips we can tell our patients? Well, it's eat fresh, avoid processed foods kind of mentality. You want to avoid instant noodles. If you can cook at home as often as you can, that's going to be helpful. If you're going out to eat at restaurants, they generally will have a low salt menu. You can ask for it at the restaurants. Get those dressings and the sauces on the side. As I showed, there's a lot of salt in those. You can buy, if you just look in the right places, you can buy prepackaged rubs that you can use that don't have salt in it. There's tons of these out there. It's very easy to make your own substitutes at home. You can use herbs and spices, thyme, oregano, turmeric. There's tons of different types of vinegar out there that will add flavor to your foods. Citrus juice like lemon and lime can be used as long as you don't overdo it. You can find these salt substitutes like Mrs. Dash. Just keeping in mind you have to pay attention to what they're substituted with. You can also make your own salad dressings at home. It's really easy. It's basically just oil and whatever spices you want to use that's not salt. Then you can add some vinegar, and then there you go. You have your own salad dressing. If you're looking for how to read a food label, there's a couple quick rules of thumb you can use. Aim for less than 100 to 150 milligrams per snack. Aim for less than 500 to 700 milligrams per meal. And you can use this table of quick cutoff values when you're looking at the food label. So this goes to that over 20% is considered high. If you look at a food label and it has over 20% sodium, that probably should not be a part of your diet if you're on a potassium restricted diet. If you look at a food label and it has anywhere between 10 to 20%, this would be a great option for a meal, and you can fit this into your diet. If it's less than 5%, this would be a great option for a snack, great option for even better for a meal. This is your kind of green, yellow, red of 5, 10, and 20% to just kind of quick justify whether or not I should eat this or not. Why does this work? Because you have 2,000 milligrams and sodium allowed in a day. You're going to have 3 meals, and then you're also probably going to snack a little bit in between. Less than 500 is a good number to shoot for. Last but not least, we're going to quickly talk about potassium. The recommended intake for potassium is 3,400 milligrams per day for males, 2,600 milligrams per day for females. Interestingly enough, the typical Western diet doesn't even reach that. It's about 2,500 milligrams per day. Why is that? That's because the things that we eat typically on the Western diet is not very healthy. It's a lot of processed foods, it's a lot of breads, it's a lot of grains. Then if you look at where the potassium really comes from, the typical Western diet does not have a lot of fruits and vegetables in it. It really does not have a lot of legumes and nuts. So that leads to us not getting enough in the day that's recommended. If you're on a potassium restricted diet, you still do need to restrict what you're taking in because you are going to be above that level. Instead of being at your normal 2,500 milligrams per day, you need to get it down to 2,000 milligrams per day. Some quick rule of thumbs, or if you're looking at a label and it happens to be listed over 200, you should probably be pretty careful with that. That's considered high, and over 300 is very high. You should probably just avoid it. Potassium is kind of the trickiest one to make recommendations on because, as I said, those come in very healthy foods. You kind of always want to have some backups when you're recommended things that they should avoid. The general theme is your citrusy kind of fruits and vegetables you should avoid, your oranges, mango, melons, things like that. You can substitute those things with those more wild kind of berries like blueberries, cranberries, raspberries. Those are all better substitutes. Suggestions for vegetables to avoid: the squashes, avocado is going to be high, tomato is going to be high. You want to have some good backups for that. So asparagus, carrots, green peas and beans are always good options. Really, just as long as you're paying attention to the portion size, the dry beans and peas should be okay. Limit the dairy intake if you can. Choose those light colored desserts over the dark colored desserts. A, it's going to have less phosphorus, and B, it's going to have less potassium in it as well. Strategies when you're talking with your patients: have some good backups and alternatives that you can use that you can suggest that are tasteful, and really focus on the sources they're getting that potassium from. Because if you get that diary back and they're eating a lot of dairy products and a lot of beans and nuts for some reason, or protein shakes that have a lot of potassium, you can cut out those areas of the potassium intake and either encourage or keep those vegetable and fruit levels of potassium, because that's also packaged with all those other good benefits, those plant proteins, those fibers, and all that stuff that we're trying to keep our patients to have a high level of intake with. So again, you can leach out those foods that are high potassium, soak them overnight is best, but at least 4 hours. It's been shown in some studies this can decrease the potassium by up to 80%. I appreciate you guys staying for this long talk. I hope I was able to get some things across, notably that these new guidelines that came out reaffirm our knowledge of diets and nutritional things that we try to recommend for our patients with CKD. I hope I was able to show that if you change your diet, this can lead to change in clinical outcomes, especially in our CKD population. Hopefully you can use the portion control techniques that I discussed, the hand methods, how to read a food label, what's considered high in phosphorus and potassium going forward. If you can learn about the nutrition and really take grip of this and get your patients to understand this, this is a way that they can empower themselves to make changes in their daily life. Instead of giving them a medication, they can do something that will have some clinical changes. And maybe it starts with changing their diet, and then they end up paying more attention to their blood pressure, and then they end up starting to exercise. So it can just snowball into a great way to get your patients to be in better health.